This is going to invariably piss some people off, but I think the nasal end-tidal capnography devices are overused and don't offer much benefit in treating patients who have sick lungs. And I can already sense the angry comments coming in, but I have largely abandoned using non-invasive capnography on my respiratory distress patients. I hear the phrase, "it's another tool," over and over again, but personally, I don't really want to use a tool that's going to give inaccurate red herrings. Hopefully, most people know by now that what many of us were always taught, that the end-tidal CO2 very closely mirrors the patient's PCO2 and that end-tidal is a poor man's ABG, is not a correct statement when applied to the patient with sick lungs. Increased dead space means decreased correlation between the end-tidal and the PCO2, and just about every lung-sick patient that we encounter has got large amounts of dead space. Even the waveform can be misleading. We are always taught to look for that shark fin waveform that indicates smaller lower airway constriction and inconsistent alveolar emptying. And this indeed is a very real thing that you do see. However, if you deep dive into the pulmonology literature, you will find that you really only see the shark fin in patients with very severe bronchoconstriction, and that in many patients with mild to moderate and even severe lower airway obstruction, the waveform can appear normal. Throwing cold water on the whole, you can differentiate the etiology of the respiratory distress with capnography. As far as trending treatments, yeah, if the patient is shark finned, you can see tangible normalization of the waveform as you treat the patient. But you must clinically correlate the findings, because the improvement of the waveform does not necessarily mean that the patient is clinically getting better, and this has been demonstrated with peak flow studies. When do I employ non-invasive end-tidal capnography monitoring? I use it on non-intubated patients who are either obtunded or who I am deeply sedating or analgesing. It has extremely important implications in pre-hospital medicine for that patient population, and especially in the particularly clinically tenuous and litigiously risky delirium with agitated behavior patient who requires a hefty dose of ketamine. Most of those patients tend to be younger and healthier, and I'm not worried about dead space throwing off my values. I can monitor them to prevent hypercapnia, and I can keep track of their respiratory pattern to ensure adequate ventilation.